our first talk I believe this is your first talk, Jay, by our new global mental health faculty in psychiatry, Yang J. Lee, and we're really excited to have him present today on his work. Patrick's going to introduce him a little bit later, but this is a jointly sponsored event with Global Mental Health, the UW Consortium for Global Mental Health, and Birch. So thank you for being here, and I want to acknowledge that we are presenting from the lands of the Coast Salish peoples, and we're honoring them and this land this land that touches the shared waters of all the tribes and bands within the Squamish, Tulalip, and Muckleshoot nations. And I give personal thanks to these tribes and bands for their love and stewardship of these places and lands and waters, past, present, and future, that allows us to enjoy this beautiful place. So thank you all for joining us today, and handing it over to Patrick.
Great, thank you, Leah. And I'll do a brief introduction and welcome to Dr. Jay Lee, who joined our faculty just a few months ago. So as Leah mentioned, Jay is an assistant professor of psychiatry in both the Department of Psychiatry and Behavioral Sciences, with a joint appointment in the Global Health Department. So really pleased to be able to co-sponsor this talk. And just briefly, Jay has a really interesting background, and has done really great work focused on sort of societal interventions to reduce mental health stigma, but also more individualized intervention that takes into account qualitative interviews and feedback from the community, with a focus on folks with severe mental illness and HIV. So I'm really looking forward to your talk today, Jay, and I will turn it over to you.
Yeah, thank you so much for the invite, Patrick and Leah, to be here. It's good to be at the University of Washington. I'm glad that I signed on. Thank you, Leah, for showing me around when I was visiting in December last year too. I thought I would start by telling you a little bit about my personal story, and then so how I ended up getting into the work, and I guess the foundation for the work, and then going into the research components. I'm from a lot of places. So I was born in Seoul, South Korea. I moved to America when I was 9 years old. And I've lived in many places in the US. I've lived in Hawaii, South Florida, Tennessee, and the Appalachian Mountains, where I went to a pretty evangelical Christian school, like Georgia, like 2 hours away from Atlanta. So I've lived in quite a few places. So all the red arrows point to all the places that I've lived so far. But I lived most of my teenage years in the Deep South, in Appalachia and rural Georgia. And I was the only Asian person in school. And that's the time of your life during your adolescence where you're forming an identity, where you're forming a role for yourself. And I thought that the only identity that I could really form in a setting where I was the only person of my ethnicity was being Asian. That had very negative stereotypes at the time. Yeah, so I didn't really feel like I was American. I didn't feel like a part of the American culture. I didn't feel really Korean either. When I'd go back to Korea, I wouldn't really, be able to identify with, being Korean either. So I felt at a loss for community. After I finished high school, I didn't feel like I was where I wanted to be in terms of my role development and my identity development. I didn't know how to articulate it at that time, but I decided to take a gap year and try to experience things as differently as possible from what I've been used to try to get a sense of where I belong. So I spent the gap year. I spent 3 months or I spent half a year, 6 months in Ghana, 3 months of which I lived on $1 a day. I also taught English in China. And throughout this process, I thought of several things. One was why do I need to be American? Why do I need to be Korean? And what does that even mean, being American or being Korean? Does that mean that I value other Americans more than I value people from outside of America? And that just seemed wrong to me that, that there's many other definitions of being American or being Korean, but that really kind of stuck out to me as something that just didn't seem right. So after a year of being around and connecting with people from very different backgrounds around the world, I decided that, I'm a global citizen. And that to me means that all lives are equally valuable, no matter where they're from and no matter who they are. And if you take that a little bit farther, it's got profound implications on how to view the world. Like we live in a world where there's vast amounts of inequity, inequality, where having like $1 or $2 in the right person's hand at the right time could save a life of somebody that's dying from malaria. So I went into college really excited and interested to make this like a mission, make this a purpose for me to try to address some of these inequalities globally. Oh, there it is. So during college, I went to Uganda. I had an opportunity with a journalism fellowship and also with research award for my undergraduate university, WashU in St. Louis. And when I was there, I made a lot of really great relationships. I made a lot of great friends. Um, on the right is Peter Weiswa, who's a professor at Makerere University School of Public Health, who I've interacted with for the past 10 years, a good personal friend now. And many other colleagues that I grew to be close with, both my people in my peer group, people a bit more senior, a bit older, in government, in academia, in the community too. And the relationships kept me coming back to Uganda. So I took another gap year between college and medical school when I went to Uganda to help a friend on a grant that he got, and did a few more projects. And eventually, this ended up morphing into an organization called Empowered Through Health. So in my first year of medical school in 2018, along with Ugandan colleagues, a couple of Ugandan colleagues, we started a ETH. So a friend of mine from medical school donated $40,000 at the time, and that was enough to get started. And we have focused on healthcare research and education. And our mission statement is that we believe that all lives are equally valuable. And when we were looking for somewhere to work, we wanted to make sure we work somewhere where, we're helpful to the government and to the local community. So, there's many areas in Uganda, and Uganda, like any country, has disparities around the country for various, historical reasons. So the area that we're working is called the Busoga region, which is a part of the eastern region of Uganda. And it's consistently got second worst outcomes in poverty levels and in health outcomes. And among the 9 districts there, Brienda district in Lake Choga. So when we started, there was no electricity anywhere in the district, in a district of almost 500,000 people. A majority of people are subsistence farmers. Almost a 50% literacy rate, and there is also no previous mental health care available. So we mapped out all the health centers in the district, and we chose an area, like a training center in Punde, that had what appeared to be like a gap, where there was no health centers nearby for general medical care as well as for mental health care. So we started operating in 2018. So healthcare is one of the things that we do. That's our health center. So we provide general health services, and this encompasses a lot of different things in a very low resource area. So we're working in a very low resource area in a low resource region in a low resource country. So So, we provide, all types of, maternity, general health care, deliveries. And in 2021, we also started providing psychiatric care. So when we started providing psychiatric care, we are the only people the only group that provides psychiatric care for the whole district for 500,000 people. And really for more than that, because although there's nominally mental health care available in surrounding districts, it's not really available in practice because of like medication stockouts, as well as maybe it's in the district plan, but the staff isn't hired or they're on leave. So effectively, we're the only consistent source of mental health care in the whole region outside of Jinja Regional Referral Hospital. And we have active collaborations with many different agencies. So, for example, we're partnering with Vitamin Angels for deworming and vitamin supplementation for all the kids in the district. And we also coordinate with the government various campaigns. So another thing that we do is education, and this goes on two different levels. One is to develop global awareness and population health research competence for Ugandan and international students. And another one is empowering the local community. So our flagship program, educational program that I'm going to talk about a little bit more, is called Global Health Experiential Fellowship. So we have over 200 alumni. I'm going to get into that in just a little bit. And we're also interested in empowering the local community. We're building a primary school. We have the funding to start a primary school and to pay for 2 years of expenses. So we've started that. That's going to open in 2026. And we also make reusable menstrual pads for distribution too. Talking more about the Global Health Experiential Fellowship. So it's a 5-week immersive experience living in rural Uganda, working together on an intercultural research team. So we did a review on this, what's really unique about this is that this is simultaneous training program. So what I mean is that a lot of times these experiences that if you're at University of Washington, you can get field experience in Uganda. You can get exposed to these different settings and get mentorship in how to do it. But sadly, a lot of times students within those low resource countries, often do not have the same opportunities, right? So we started this fellowship, and the idea is we pair Ugandan and American pre-doctoral students. So it's a combination of undergraduate, master's, and doctoral, usually medical students, MD students, with Ugandan and American combined. And they work on teams of about 6 on average, and they work on a defined research project with mentorship. So we did a review of this fellowship, and the qualitative findings were generally that it was really expanded research capabilities, confidence, increased world perspective, and the quantitative. Although we had a very small sample, so we can't really generalize, but the quantitative aspects of it. So we use a measure called Akira, which is a measure of research assistant competency. And so as you can see, there is a significant improvement, pre-score and post-score. And the American fellows actually didn't exhibit a significant improvement, but the Ugandan fellows really exhibited a huge significant improvement. So that's what we want to see. And American fellows, I think they benefited from other aspects as well. So this is ongoing. We generally work on global mental health projects, and this has been an engine in which we've been able to collect a lot of preliminary data. And research things that we do. So our research questions very much arose from experiences providing direct healthcare. So generally, our approach that I'm going to talk about a little bit later is, being community informed, and meeting the community where they're at as well. The two big areas that we've been working on is addressing demand side barriers and working with existing community structures to deliver effective mental health care. So both working with demand and supply. So this is our approach generally. It's probably nothing that novel for you guys to see. But first we gather preliminary qualitative data, and then we do a co-design session with the key stakeholders identified in the preliminary data. We develop an intervention. We test the effectiveness of intervention, and then we try to scale it up. So now I'm gonna go on to talk about individual projects that we've been working on. So mental illness stigma. So we talk a lot about how to improve the delivery of mental health care, but the truth is that the treatment gap for mental illness demand is like a very large portion of it too, right? So a large part of that demand deficit is mental illness stigma. So, background, 70% of people with mental illness globally receive no treatment. It's one of the largest barriers to treatment seeking for people with mental illness. So when we started providing mental health care, so this is what got us into it. So we were covering 500,000 people, but we were receiving less than 5 patients per month. So, it's not because, there's not people with serious mental illness, but it's just that people weren't coming, right? So it seemed like addressing demand side barriers was the first step. So we've done quite a bit of formative work on this. So generally speaking, we've we've done work using vignettes because mental illness as defined is different, right? For example, there's not like a single word for depression in Lusoga, the local language, right? So when we're asking questions about this, we use a vignette that basically illustrates somebody with depression, and then we've seen like what groups of people are the most stigmatized, and what's so stigmatizing about mental illness. And what we found generally is that psychotic disorders are the most stigmatized, followed by depression in men and substance use disorders in women. And we've done other works, examining mental illness stigma in Uganda in the works. So this is an example of an intervention that we did when we started providing mental health care. So we borrowed from HIV literature, which showed community theater interventions for reducing HIV stigma. So you're like, oh, okay, HIV and mental illness, many similar qualities. They're both chronic illnesses. They're both highly stigmatized, and we can learn a lot from HIV literature for treatment of mental illness, or how to deal with the stigma with of mental illness as well. So what we did was, we did focus groups, 4 focus groups, discussions to find the current beliefs and attitudes towards severe mental illness. So what makes it stigmatizing? And based on that, we developed a criteria, like a list of criteria that competitors would need to meet in a play that they designed. And we had 4 teams from the community compete for the most entertaining play that met those criteria. And the winner got to tour around and show the play. So this is like the flow chart of the intervention. So we administered an initial survey, and then some of those people attended the other intervention, and some of them were interviewed later, 1 week later, and some of them were interviewed 1 year later to evaluate long-term effects. So what we found is that personal acceptance scale, so it's a scale that's supposed to measure proximal public stigma. So a question might be, how do you feel about having a neighbor with mental illness? And we found a very significant improvement. Effect size was about 1.0, so like very large effect size. And it was similar for broad acceptance scale, which measured more like distal public stigma. So an example there might be spending money on people with mental illness is a waste of money. And so that likewise showed a very significant improvement. And you can't really infer causality from this, but the average number of mental health patients that we see increased from like around 5 per month to around 100 per month. Um, and most of these people that we see, or almost all of them, are people with severe mental illness, so with psychosis, like mania. And so depression is still not really regarded as something that's treatable or is something to really talk about, especially among men. But the issue with this approach, so the play ended up, focusing mainly on severe mental illness, and also community theater is not easily scalable either. It requires a lot of resources. It requires transportation. It requires, a bunch of people to be there at a certain time. So it's not like a very scalable intervention. So what can we do? So I'm submitting a K23. I'm resubmitting it actually. It's developing and testing a community-led radio intervention to reduce depression, stigma in rural Uganda. So we did it for psychosis. So now we're trying to do it for depression. So we did a media preferences study that showed that radio was, kind of like the preferred medium in Uganda that is also equitable in terms of like more people having access to it. So the first step will be to co-design with the key stakeholders, and we identify media preferences study, and then we finalize and pre-test prototypes for clarity, resonance, and perceived effectiveness, and then we pilot test it. So the idea is that first we're gonna do it in listening groups for a K level project, and for our R1 level project, do it live. Meaning we actually put it on the airwaves and measure it and measure the impact. And this is another intervention that we've started to develop. So collaborative models of care for severe mental illness. So the background on this is that healthcare in Africa is pluralistic, which means that there's many different providers that people might go to for physical conditions, but especially for mental health conditions. So research shows about 50% of people with severe mental illness in Africa turn to traditional healers and religious leaders as first providers of mental health services, data that's also backed up by our preliminary data. And collaboration between traditional and faith healers and biomedical providers have been shown to be effective and cost-effective in Ghana and Nigeria. Oya Gureje has done really great work around this. But in Uganda, it's quite different. The system is quite different than in Ghana and Nigeria. So in West Africa, there's prayer camps where there might be hundreds of people with severe mental illness that are all together, kind of under the stewardship of traditional and faith healers and they pray together and they recite the verses together. And there's some, very controversial methods there, like fasting, like chaining, things like that. But that doesn't really exist at any large scale in Uganda. So it's more of an individualized thing. So you might have a community traditional healer, or you might have like the local pastor who tries to pray for that person on an individual basis as a part of his congregation. So it's quite different. The same model cannot necessarily be applied in somewhere like Uganda. And so we've done some preliminary work around this. One is to find the pathways to care for psychosis. So what do people do when they have psychosis? So it's a mixed methods study. And then we also did a qualitative study on what the providers think about people with severe mental illness, like what they do. And then we also did a qualitative study on levels of mental and stigma among the providers. So this summer, we just concluded data collection a couple of months ago. So we did some workshops on perspectives on collaborative intervention model for severe mental illness in rural Uganda. So we had multi-stakeholder perspectives, people with lived experience, family members, different providers, community health workers, and we used a model called Navigate, which is a gold standard model for first episode psychosis as a template for discussion. So components of Navigate, this is a gold standard model in the United States, developed BU. So components of Navigate are individual resiliency training, aimed targeting the person with lived experience, supported employment and education, family education program, and personalized medication management. So for the workshops, we had two separate groups, one with Imam as a religious leader and the other one with the pastor as a religious leader. So one was held in the mosque and the other ones were held in church. And we mainly did this out of logistical reasons, because the Imam had access to the mosque and the pastor had access to the church, and they were good community meeting places. So in workshop one, we sort of rehashed what we had found in our preliminary research, and the reason why we rehashed it was because we thought that getting everybody on the same page was necessary, or gaining a shared understanding among the stakeholders was necessary. And then in the second workshop, we presented an overview of Navigate model and asked about analogous systems and how it could function in Mpunde. In workshop three, sought to develop more of a model behind it. So including reviewing a scenario of somebody with severe mental illness, how that person could be helped. So generally, the findings were that for psychosocial care, there was religious leaders who are identified as most trusted potential counselors. Now, this has a caveat that this was done in church, right? So, or church or a mosque. So that might be a biasing factor. Medication, they were thinking that family and community health workers support that adherence and any medication adjustment once biomedical providers see them. And biomedical providers assessing readiness for occupational support and families subsequently coordinating support. And for families, for family interventions, participants thought that families should be very closely involved with all aspects of care too. But there are challenges of conducting such workshops too. And a big challenge was that being with ETH, we're seen as biomedical providers, right? So there's a natural bias in terms of maybe favoring biomedical providers and social desirability bias. And the people in the groups had different levels of community standing as well. So while we took turns and we took measures to ensure a mitigation of that power dynamic, I'm sure that it seems like that still showed through. And in a particular way that it showed up was that religious leaders and biomedical providers would gang up on the traditional healers. Well, not directly at them, so they didn't disrespect that traditional healer and that stakeholder, but they made a lot of statements disparaging traditional healers as a whole. And that might not be the best approach if you're trying to get people get people involved into the system. So I wrote about this in one of the papers, but I thought that this is very interesting because the religion, well, Islam has been there for like a little bit longer than Christianity, but Christianity came with the British, right? And the British also came with the biomedical forms of understanding healthcare too. So kind of makes sense that those are perceived as more legitimate state sort of institutions, more with more authority than old practices. So that's something that we're going to need to work with, or we're going to have to try to mitigate it for developing an intervention. And so I think this is more applicable potentially than the model working with prayer camps in Nigeria and Ghana, because even or more generalizable. I mean, because like around the world, there's like community centers, there's churches, mosques, and working with that religious leader and involving them in that somebody that people like really trust in management of severe mental illness could be really helpful, right? So I think it could be more scalable or more generalizable than the model in prayer camps in West Africa, if we can find a way to make this work on an individual basis. So this is another project that we've started. We haven't done a co-design yet. This Patrick actually helped review this too. So suicide is something that's incredibly stigmatized in Uganda. So stigmatized that the traditional practice in the area is that when somebody completes suicide, uh, people beat the body, and that person cannot have a funeral, which is very significant in a society where the funeral, the burial, and the introduction ceremonies are the two biggest ceremonies in somebody's life, right? So if somebody hangs themselves in their house, they cannot come out through the front door. They gotta make a hole in the wall, and then they gotta drag, and they gotta carry that person through that gap. So very highly stigmatized, especially in like rural Uganda, like where we're working. So what we did was we did in-depth interviews with 18 suicide attempt survivors, 17 of the family members of the suicide attempt survivors. One person that we interviewed didn't tell anybody, even like family members, about the attempt. So we didn't interview a family member about that. 10 healthcare workers and 9 community health workers. So precipitating factors. I didn't put like economic things here, but uh, relationship conflict often stemmed from economic issues. So, for example, like not being able to provide resources, right? It turned out that 16 out of 18 people that we interviewed were men. So that was like especially pertinent in this sample, in like a very patriarchal society where gender norms are very prevalent. Like a man not being able to provide, that was like often like precipitating factor as well. So psychological factors, mental illness, substance use, and a lot of stigma as well. So after attempt, there was a lot of courtesy stigma as well, like the whole family being shunned that they were from. And but people found some helpful things like faith-based coping, uh, working on relationships with people in the community. So this is a potential target for intervention. It's a bit hard to do research in suicide because one's so stigmatized, and two, it's difficult to find people who have attempted suicide, and they might not be very forthcoming about it. So it's very challenging. And it's also illegal to attempt to complete suicide in Uganda, as it is in a lot of countries around the world too. So that's another obstacle. So this is another project that we've started doing preliminary work on. We finished data collection a couple of months ago. So about 40% of primary school aged youths have discontinued school in Uganda. In the district that we work, it's a lot higher. I remember going to a primary school, and there's about 200 kids enrolled in first grade, and by the time that they get to sixth grade, there's only 10 people enrolled. So, like a very, very high like attrition rate in these schools. And I could talk a lot about the reasons why that might be the case, and why it might be worse in the area. But I think we have some time constraints. So we collected some preliminary data with people who have discontinued school, with family members, school teachers, and community leaders. So with people who have discontinued school, we only interview them as adults. So the criteria is that they are between ages like over 18, like I think between 18 and 24, and the event had to be like a few years behind them. So and the idea was that people could reflect like a little bit more on what happened, and interviewing adults is generally preferred than interviewing kids. Um, So reasons for school discontinuation varied. Some of it was, family stressors, like running out of money was probably like the biggest thing. Also very gendered drivers too. Like, for example, somebody would be on their periods, would be menstruating and they wouldn't have any pads, right? So, that makes it hard to go to school if you miss school, whenever you're menstruating. And another thing was harsh punishment from the teacher. So like corporal punishment is very common. So that was another factor as well. So primary school is supposed to be free in Uganda, but there's other requirements like buying school supplies, buying uniforms, and that are all obstacles to going to school. And so psychological sequelae, there is some stigma as well for people that discontinued school. Like societal stigma. So some of the participants just stayed at home, like not doing anything for maybe like a year or so. With symptoms of depression, it seemed like. And something that was really missing is school-based counseling. There was like really not any type of counseling available at most of these schools before, as people were, discontinuing school. There was, like very limited amount of mentorship available. If anything, it's kind of like somebody, like a family friend, giving them like a limited job, like, okay, let's, go till the fields and we'll pay you X amount. So nothing like that really builds skills in a structured way. So this target for intervention that people that were very interested in as well. And we also did some preliminary data collection on pathways to care for depression and HIV. So we also completed data collection for this about 2 months ago. So, you guys probably all know this, but it forms this endemic where each condition amplifies the other's impact. So we did two projects similar to the preliminary projects that we did for severe mental illness, where one was pathways to care for HIV and depression. So we interviewed 150 people with HIV from ART clinics and 154 HIV negative individuals from just random sampling in the community. And 28 of the 150 of HIV positive patients screened positive for depression, and 23 of the 154 HIV negative people screened from the community screened positive for depression. And we conducted in-depth interviews for all of them. And we also identified what the potential providers of care for depression and HIV think about this endemic, and like what their current practices are. So one thing that was like really striking from these interviews is that it seemed depression seemed like very gendered to a degree, meaning both sexes had both genders had reported similar rates of depression, but the way that it presented was very different. So for men, it was they wouldn't like really talk to anybody, and they wouldn't really want to admit want to admit that there's like a problem at all, and that wasn't really the case for women, which was very interesting. Makes me wonder if the prevalence rates of men with depression and prevalence rates of women with depression, like how much of that is kind of like a bias because men feel hesitant to admit that they have depression. And so I think a lot of these lessons from Uganda can be translated domestically as well. Kind of view a lot of these projects in Uganda as trying to leverage community and social connection to improve mental health outcomes where there's not the same amount of resources that there is in the United States. Uh, Now, it doesn't mean that it's like this like ideal kind of society where people are very connected and things like that in Uganda. In fact, when we administered the UCLA loneliness scale, the people reported similar rates of loneliness as they do in the United States, although they're around people all the time. So it kind of seemed like being a part of like a very communal society where everybody knows everybody in like rural Uganda. It can also be isolating because you feel like it seems like people feel like they need to present a certain type of image. People don't really feel like they can be who they want to be. So, it's not like this like, utopian sort of high, community connection community. But there's things to learn from the different community structures available in Uganda. So it seems that in the US, as a psychiatrist and also as just a person that lives in the United States, that social disconnection is like a major issue, and research shows that social isolation is a major risk factor for suicidal behavior. So what I'm thinking about is, so I work at Harborview Medical Center as an inpatient attending. That's my clinical role in addition to my research role. In first month, post-psychiatric hospitalization is a very high risk period for suicide. And people, just anecdotally, people say that, oh yeah, here, we have like all these groups, we're talking to people all the time, but as soon as we get out, we're kind of like on our own. So this could potentially be a target. Applying global lessons, community-led approaches. Like Harborview Medical Center already has peer bridger program, right? So can we leverage that program to increase social connection as well? And how do we also build meaningful social roles for people that have mental illness in the United States? I appreciate people's thoughts on this as well as a direction that we're really thinking about. And that's the presentation that I have. Thank you for your attention, and open to any questions, any discussion. Love to hear your thoughts.
Okay, it looks like we have a comment from Teresa in the chat.
Yeah, so positionality, is obviously like an issue. Doing qualitative research, being affiliated with like a healthcare organization, that's regarded as despite our kind of efforts, as regarded as like Muzungu organization, like the Muzungu is a foreigner organization. So that's definitely an issue that we talk about in each one of our papers. So the answer is so I guess is in analysis and data collection and analysis. So yeah, it's Ugandan people that speak Lusoga and English that do the data collection. But sometimes for some of the interviews, there's an American or somebody that's not Ugandan that's a part of the interviews as well. They don't ask any questions, but they observe. So that obviously leads to some positionality issue questions too. But so does having a Ugandan person who's not directly from the community and who's affiliated with ETH, like a healthcare, regarded as like a biomedical healthcare organization, administering the interviews. So I guess we have like different types of ideally we'd have like data collectors from the community or that are maybe not from like the town or so that can administer the interviews or trained to administer the interviews. But sometimes that's very difficult, right? And if people living in the rural area of Uganda sometimes think that people coming from the town, like more urban Ugandans with professional jobs, there's also like a definite like power dynamic there too. So basically, I don't know if that's like a great answer, but it's like I acknowledge that it exists, and we can try to mitigate it, but that it exists and is something that we just have to acknowledge. For data analysis, is a team of Ugandan and American people. Each transcript, there's like one, at least like one Ugandan and one American that, that code separately, and then they compare notes and so forth.
We have one more question in the chat.
Just wondering if you see any developing questions around the role that non-mental health specific interventions have on mental health in these populations. Yeah, so I think that's a great question. So from our qualitative data research, a lot of depression, anxiety seems like driven by poverty in this area. And by absolute poverty. So, food insecurity, and lack of economic resources. So like some real absolute poverty, like living below $1 a day and struggling to meet like very basic needs. So that kind of got us interested in the school discontinuation project. So what if we catch people at this like very critical at this very critical juncture of their lives when they're discontinuing school, and then we couple that with both a psychological and a occupational like vocational intervention too. So I think that there's definitely like a major role for that to play.
Right. And one more question about any future Empower Through Health projects that you foresee.
Oh, hi Haley. Good to see you. Hope you're doing well. So yeah, I mean, like I guess like a big project that we're doing is building a school, building a primary school, starting a primary school. We're looking into different ways that it can be an innovation as well. Um, so I think that's like a very big sort of project for ETH going forward. So I think we think that healthcare and education are the most important tenets for helping people, for helping society. So those two are going to be our focuses going forward as well. For comorbid HIV and depression, do you know if effective antiviral spray improves patient outcomes?
Yeah, skill. Yeah, I was just wondering if depression might be attenuated by effective antiviral treatment.
Yeah, hi, Gil.
Yeah.
I'm not 100% sure, but definitely treating depression increases ART adherence and reduction of viral load, and that's been very well established. But I don't know if the causality has been established the other way in the other direction.
Yeah.
But if you treat depression, it's shown that it improves HIV outcomes as well.
Thanks.
Yeah, I appreciated a lot of aspects of that talk and your conceptualization of the demand side and the supply side and your kind of your efforts in both of those areas. Regarding the demand and addressing stigma, also it's helpful for us to be reminded that stigma is not just what we feel about ourselves if we're experiencing mental health, but it's actually how people are getting treated by loved ones in society and healthcare
Mhm.
professionals, et cetera, and your efforts to uncover that. Um, I am curious about, could you describe kind of your progression from originally focusing on folks with more severe mental illness like psychosis or post-suicide attempt, and then moving on to thinking more broadly about mild to moderate depression and kind of moving in that direction?
Yeah, so to me it seems that we know like depression is like prevalent, but people, it's not really like a discussion at all, and especially with expressing how people feel depression, it's not really at it on people's minds, right? So we have this intervention. We could do like a better job in terms of, or we could like scale up that intervention for psychosis as well, but it kind of seemed like depression. If you think about depression and mental illness stigma, and depression, manifests oftentimes from low self-worth, from like not feeling like they belong, and stigma can just kind of like reinforce that. So I think that is like a very important target for depression stigma is a very important target when we're talking about mental illness stigma. Um,
I have a question about, it seemed like you had just a tremendous number of sort of beginning studies in the works, things that you'd started. Is that in part because of your global health experiential fellowship? Are your fellows doing that work with you?
Yes,
Yeah,
yes.
that's exciting.
Yes.
Feels like a real driver for change and rapid, discovery.
Yeah, yeah, definitely, definitely. It's like it's a challenge in terms of like, getting everybody like up to speed on, data collection and doing like trainings like rapid fire. But it's worked out more or less recently. And as the years go by, the process gets better every year as well. So it's been gets smoother and smoother each year.
Great. Thank you so much. And I just want to, I think we have time for a couple more questions, but just want to encourage people to fill out the survey as well before you sign off today. It looks like Teresa has a second question.
There is talk about wellness and the potential for including wellness to address stigma. Uh, I'm not quite sure what that means.
Teresa, can you unmute and
I can. Yeah. So in terms of assets and well-being and kind of interventions that focus on like whole health and well-being,
Mhm.
has that come up in any of the talks? Because I think there's like such rich cultural things that can get at that and make the topic of depression and mental health and easing into conversations about taboo subjects like suicide a little bit easier. I just wondered if that's come up in your work at all.
Oh, it hasn't, but it's something that we should look into. Yeah, I'm reading your I'm reading your profile and UW, and it seems it'd be very interesting to talk to you. Maybe I think I'll reach out.
I'm curious about how you're developing the content, and maybe you talked about this a bit, and for the radio programs. Are you kind of going to do a competitive project like you did with the community theater, or how will those scripts be written for the radio?
Yeah, we're not going to do
Discussions?
we're not going to be doing a competitive process, I don't think. So, what we're saying is that we're going to have three different, or in my grant that I'm submitting in a week or two, we're going to have like three different groups, like three different village groups that are like 3 kilometers apart to minimize like spillover. Come up with messages. For addressing internalized and public stigma. I think, as Patrick said, internalized stigma kind of comes from it's reinforcing public stigma is reinforcing like the internalized stigma is internalizing like the public's attitudes towards mental illness for that person. So it seems like addressing both is important. So the idea is that they're gonna have sessions in discussing stigma and then talk about who the most effective spokesperson might be. In the media preferences study, it seems like it might be the community health workers or biomedical health workers that are very effective for like the local community settings. And then they're just gonna like workshop like different types of ideas and see what works. And among the PSAs that people make in those three different groups. We're going to pre-test all of them in like aim two. So people are going to judge, how effective that they like perceive effectiveness, and like and rate them and we're going to pick the best ones to test.
Thanks so much. Any last questions for Jay? thanks so much, everyone, for joining today. Please complete the survey and great outcome connecting you to senior faculty.